So a very good evening to all of you, and myself, Dr. Neeraj, and I'm going to take this class for all those EDIC 2 participants. And basically, this class is for obstetric emergencies. So we'll be discussing the clinical case scenarios, and there are lots of meanwhile, because it's a regular class, so I will be not examining you all, but just few rules before I start this class is that please kindly mute yourself. If you have any questions, that you can ask directly the writing in the chat box. And if you want to ask any problem in between that you're not going to get understand all those things that what I'm discussing, so for that you can definitely unmute yourself and you can ask the question. And because this is the class in which I will be discussing few scenarios. So the domain is obstetric emergencies. So here is a case scenario. So this is how we used to take exams for all those EDIC two participants who are going to appear for the exam. So the scenario will be like this: a healthy 28-year-old G2 P1 admitted to labor and delivery at 28 weeks of gestation, complaining of severe headache and blurred vision. So these are the two important findings that this patient is having. And then after that, her blood pressure was in a range of 200 by 110 with 2 plus proteinuria on urine analysis. And then again, the repeat blood pressure was taken and it was showing 160 by 110. So next reading was 160 by 110. And the lab parameters has showed a normal hematocrit, a normal platelet count, and the normal liver transaminase level. So all those lab parameters was almost normal. So on taking the vital signs, the blood pressure was 180, 110. The heart rate was 123. The patient was not very tachypnic. It was only 25. She was taking 25 breaths per minute. The temperature was 34.2 and she was maintaining a good oxygen saturation of 98. On doing a quick physical examination, the patient was not having any pallor or icterus. Only that what has been noticed was the swelling of the hand and face. And on CNS finding, the patient was repeatedly complaining of blurred vision and then severe headache. And on lab examination, based on the routine examination of urine, on 24-hour urine sample, the protein was more than 300 milligram. So this is overall findings. So based on that, I can ask in the real exam that how will you define preeclampsia and severe preeclampsia? Then you have to enumerate few of the appropriate laboratory investigations that are necessary to establish the severity of the preeclampsia, and then how this patient has to be delivered and how she will be going to get managed, whether you will do a expectant management in this patient or you will be going to deliver this patient. If in between the patient will have a convulsion, so what will be the cause of convulsion in third trimester of or in puerperium, because many of these patients land up into from preeclampsia to eclampsia. So potential causes for that convulsion has to be maybe asked in your examination. And then what are the agents that you will be solely take care or you will be solely going to avoid in managing the hypertension in this preeclamptic patient. So these are 5 sets of questions that may be asked in your exam, although every time the scenario is going to get changed. So the answer, you have to know the definition, and the definition should be very precise. The value should be very precise, like SBP more than 140 and diastolic more than 90, and there must be 2 cardinal features like proteinuria should be there. So these are all findings which is showing that the patient is having a sustained hypertension, making your diagnosis as a preeclampsia. Okay, now coming to the next part. If the patient will have a systolic blood pressure of more than 160 with a diastolic of 110 on at least two occasions, and at least 2 hours apart, with all those, any of these findings, then you can label this patient as a severe preeclampsia. So then you have to understand that what is the proteinuria that is coming in that urine, whether it is 300 milligram or it has crossed more than 5 grams, whether the patient is having oliguria in less than 24 hours, the urine pouring is only less than 500, the patient have a elevated serum creatinine values or some sorts of edema, or patient that headache is now going to get a persistent one, the patient is now going to getting a persistent visual disturbances, the patient throwing some seizures. The patient will now started complaining of right upper quadrant pain, as well as along with a elevated liver function test or liver function test. Then the patient may have some derangements in the coagulation profiles like thrombocytopenia, or the patient will have a decreased amniotic fluid leading to your oligohydramnios, or there may be some IGR type of thing or placental abruptions. So this is in nutshell overall the problem with these patients. If you're going to diagnose these patients as a severe preeclampsia, like you have to tell these definitions, that how a patient will have a preeclampsia and how the preeclampsia is defined and how a severe preeclampsia is going to get defined. So all these finding, at least in many of the exam, what I saw that few of the students spoke few of the students tell all these sequences and many of them miss. So that has to be remembered. Okay. Now coming to the next part is laboratory investigation that are necessary to assess the severity. So which laboratory or which lab investigation is very, very important for labeling the severity of the preeclampsia. Now for this, you have to answer in this order only. Like it has to be CBC. Why? Because I want to exclude the coagulation defect like platelet count. I want to check platelet count. Sir, I want to see the blood urea nitrogen, whether there is any uremic symptoms in this patient, or whether the patient is presenting with a very high serum creatinine, or the patient is having some form of acute kidney injury events, or whether the patient is showing some transaminitis or high bilirubin, deranged coagulation profile. So I will go with many of these students miss this part. Blood typing and antibody screening. This is very important. They used to tell all those three findings, but they missed this. So here the blood typing, grouping typing, as well as antibody screening is very important because of the your RH incompatibility that has to become in your mind, and you have to think like that. And then 24 hours urine collection, of course, that is again very important. Now, again, the question was that what were the potential causes of convulsion in this third trimester of perineum? So if you'll see that convulsion during this specific third trimester or if a patient has delivered a baby and then she's having a seizure, so until proved otherwise, you have to think of these two causes. Now, what in the real exam, what the problems with the students is that they used to tell this cause very commonly: hypoglycemia, first cause; intracerebral hemorrhage, definitely; and third, this cause they used to miss. So this is your until prove otherwise. If the eclampsia is there, so epilepsy is, the patient is already having some history of epilepsy background or in the previous history, but CST, cerebral venous sinus thrombosis, ICH, intracerebral hemorrhage, and hypoglycemia. So these are the three until prove otherwise the cause for the seizures in the late or early purpurium or in the late trimester of the pregnancy. Now, next point is what agents that you should avoid here in these groups of patients for managing severe hypertension. So this is again the very specific list with all explanation that in your exam you have to explain at least. Okay, sir, I will be thinking of ACE inhibitors and ARB2, but the problem is that in the management, because it can lead to neonatal renal failure, and it has more delayed onset of action. It takes around 1 to 4 hours to act. So I think ARB and ACE inhibitor has to be avoided in these groups of subsets of populations for managing your blood pressure. But even what about the nifedipine? So what is school of thought nifedipine says that nifedipine, if you are using nifedipine in conjunction with magnesium sulfate, because many of these patients requiring a magnesium sulfate infusions also, considering these patients as a eclampsia, because the seizure is also very predominant. So the co-administration of nifedipine along with magnesium sulfate is not very much advised, because it has an exaggerated hypotensive response. So that has to be remembered in your mind also. Many of the time, student used to tell that we'll use that nifedipine for managing these patients. IV nifedipine can be used or oral nifedipine can be used, but if the patient is on magnesium sulfate, you have to avoid that. So commonly used drug for these acute settings for managing is definitely first choice is Hydrala, then your labetalol, and then your nicardipine, and then only the last choice is nifedipine only when if magnesium sulfate is not given concomitantly. So these are the things that you have to remember. Now coming to the next vignette, the similar case. Now we have managed this severe preeclampsia. And now after 1 week of preeclampsia, now she started complaining of abdominal pain. Now she was having abdomen pain with some associated nausea, but her blood pressure was normalized by using all those drugs that what I have discussed right now. But peripheral blood smear shows few helmet cells and few burr cells. So if you can very well appreciate this, how a helmet cells look like. So this is your helmet cell. This is your again, I think this is again helmet cells, and few of them are cystocytes. So these are basically cystocytes, which is also known as helmet cells. So on peripheral blood smear, so these two were seen, and then the patient was having a increase AST and increase ALT. The haptoglobulin level was reduced in this patient. So again, it's a hint that serum haptoglobulin is going down. So what probably differential diagnosis that you will think in this patient? And then the serum bilirubin was very high, and the platelet was again in going to a downtrend. Although it was not very low, but it was below 80,000, 88,000. Now the questions. So there are again 5 sets of questions that we used to ask in our exam when the your student will be there. So first I will, because this is going towards, you have to appropriately think of the diagnosis that this is basically a HELP syndrome, because hemolysis is there and the patient is having a elevated liver enzymes and low platelet. So now based on these questions, what diagnostic criteria that you use for differentiating a patient for a HELP syndrome, and can you classify the HELP syndrome? What are the 2 most commonly used classifications that is used for the diagnosis of HELP as a diagnostic criteria? Now, again, here the problem is many of the people used to tell one diagnosis, but the second one is mostly missed. And then what are the 5 differential diagnoses? Many of them students used to tell 3 differential diagnoses, not all 5. And then what are the complications? Many of them used to tell. And how will you manage HELP? Again, this is again very important topic. And then what is the role of systemic steroids in managing the HELP syndrome? And then what are the indications of cesarean section cells in HELP syndrome? So just see one by one what are the answers. The first is your Mississippi classification. The higher the classification means, if the classification is 1, the severity of HELP is very, very high. If the classification is 3, the severity of the HELP is very, very low. So it is more severe HELP, it is less severe HELP. And why? Because the platelet is less than 50, the AST/ALT is almost more than 70 international per liter, and LDH is almost equal to 600. So here, these both findings are equal in all 3 groups of patients. Only the problems, differentiation in Mississippi is based on the platelet count. So platelet has got too much of importance. The second classification is Tenney's classification. Here you have a 2 classification, like partial or a true or complete Tenney's classification. So how will you define true or complete? If the platelet is less than 1 lakh, if ASD is more than 70, it is just like if ASD more than 70 and if LDH is more than 600. So if platelet is less than 1 lakh, so it is Tenney's true type classification. So Tenney's partial, if the patient is presenting with severe preeclampsia with any of the following, like the patient will have elevated liver function, the patient will have a like absence of low platelets, or the patient will have a absence of hemolysis or very low platelets, or patient will have a low hemolysis. So based on that, this is classified. Now, how will you do a differential diagnosis? So these are the straight away differential diagnosis. TTP-HUS, AITP, that is autoimmune thrombocytopenic purpura, and then viral hepatitis, and then your acute fatty liver or pregnancy. Okay, now complications of the HELP, again, very straight away. We all know that these HELP syndromes will not going to get managed. The patient will land up in DIC. The patient will have a pulmonary edema, or the patient will have a ARDS. The patient will have a ARF. The patient will present with hepatic capsular or hepatic infraction or periportal liver dysfunctions will be there. The patient will maybe in having a ARDS, just what I spoke about this. And then placental abruption, the last common complications, again placental abruption. Many of these patients will develop because of the coagulopathy and because of the that DIC. Now coming to the next part, here you have to remember this hepatic rupture. Now coming to the next part, so how will you manage? So the management is, first you try to deliver the fetus, and placenta is the mainstay of the treatment, because if you're going to deliver this, if you're going to deliver the fetus, the patient will be getting benefit from the HELP syndrome. Timing of delivery is always very, very important, because it depends upon the severity of the syndrome. So maternal fetal stability as well as gestational age has to be taken care of. Now, these patients always provide a symptomatic treatment or supportive treatment up to till the patient will getting a delivery, reaching a delivery point, and it has to be managed in SDU and ICU. So this is one of the, again, limitation. Many of these patients, if maybe the SDU and ICU setups has not been provided, leading to more and more maternal mortality. And then the delaying the delivery for a period, it has a significant effect on the fetal maturity as well. And then administration of systemic steroids, okay, they have shown to reduce the risk of your neonatal respiratory distress because of the surfactant problems. That's why if you are giving a systemic steroids in these groups of patients, maybe you will prevent the risk of neonatal ARDS or neonatal RDS. Now, any role of systemic steroids in HELP syndrome? Now, the use of systemic corticosteroid in HELP syndrome may increase may increase the platelet count, that is maternal platelet count, but it has not shown to improve the your infant mortality or maternal mortality. So it doesn't improve the progression of the disease. So if the disease is progressing, it will progress. It will the halt in that disease process will be not there, and the patient will have a maternal as well as infant mortality. So it's a Cochrane database in which they have given a conclusion that systemic steroids in the HELP syndrome may increase the platelet count, although, but no effect on the maternal morbidity as well as infant mortality, and in never it will affect the progression of the disease. Now, how you're monitoring this patient? So these fetus should be continuously monitored with cardiotocography, and these deliver the fetus once the mother is stable first. The vaginal delivery is not contraindicated at all if the cervix is very favorable and you are getting adequate dilatation. And but if HELP syndrome is coexisting, you can consider high dose of steroids and involvement of renal anemia. It's a case-to-case variations, but many of the time it doesn't say that you have to go with a high dose of steroid. But if HELP syndrome along with some involvement of renal or liver problems are there, then you can go with this. And in the third stage of labor, it should be managed with 5 to 10 units of oxytocin rather than using symptometrine or ergometrine, because ultimately it will increase the blood pressure in this patient and it will have more poorer or unfavorable outcome. Now, what again, the question was there, what was the indications of your cesarean sections in HELP? So similarly, the first, if the non-reassuring fetal status of the patient is there, and if abnormal fetal like breech presentation or like cephalic presentation, not mostly breech presentation or cephalopelvic disproportion is there with a BSUP score of less than 5, and the period of gestation less than 30 or period of gestation less than 32 weeks with IUGR is there with a BSUP of less than 5. So all these patients require emergency cesarean sections, and even the patient will have a subcapsular liver hematoma or any abruptio presenti. So these are few of the indications for the cesarean sections. Now coming to the next point, next vignette. Now this patient was taken inside the OR. Okay. Why? This HELP was planned that we will take this patient for inside that OR for cesarean section. Why? Because the patient was having a abnormal presentation of the fetus. Now here, what has happened? After starting LSCS, the patient was hypoxemic. The SpO2 was drastically falling from 98 to 82%. The patient started off sweating, shivering, dyspnea, cyanosis, and bronchospasm. And vitals were 78. The BP fall very rapidly, 90/40, and the respiratory rate was, the patient was very tachypneic as well. So at this point of time, what you will make differential diagnosis in your mind? So these are the few questions. The first, what are the different risk factors for amniotic fluid embolism? And then what are the pathophysiology? I'm very interested in asking that what are the pathophysiology, how these hypoxia will be developing in patients with AFE, and what could be the other diagnosis that you will consider in this patient with same cardiorespiratory compromise or profound cardiorespiratory compromise if a patient will have. And then what are the parameters in DIC score? I'm more interested in asking about DIC score, whether you all guys have understanding of DIC score or not. And then when you will say that it is overt DIC and when you will say that it is a DIC is positive. And this is again a very, I think, a tricky question, that what are the few biomarkers that have been there in the literature for the diagnosis of AFE. I think previous batch, they doesn't have named any of the biomarkers because they were telling that we haven't read about these biomarkers. I don't know from where you have got this question, but yes, just for sensitization or making you sensitize, I have added this point that at least you name 1 or 2 or 3 biomarkers. If you're giving a good answers in the real time exam for the EDIC2, many of the examiner can ask these biomarkers. Have you heard about these biomarkers and all, and how you are going to manage this AFE patient? So we will have discuss about AFE in very short. First, the risk factors. Definitely in this patient, the risk factors was the patient was having a fetal distress because the abnormal presentation, the fetus was there. Although the risk factors can be grand multiparity, instrumentation, delivery, if the patient is having advanced maternal age, more than 35 years of age, if the patient is having a forceful uterine contraction and you're inducing the labor, all these are risk factors. If the patient is already eclamptic, and if the cervical lacerations has happened, if the patient is having a placenta previa along with abruptio placenta. So these all are findings for a amniotic fluid embolism. Now coming to the potential pathophysiology. So these hypoxia in AFE is felt to be secondary. Why this is secondary? Because one or in combination with significant ventilation, there is a significant ventilation perfusion mismatch that is going to happen. How this will be happening? Because of the pulmonary vasospasm, because of the pulmonary edema, because of the bronchospasm. Why this will be pulmonary edema? Because of the LV dysfunctions, because this patient will have a acute LV dysfunctions, lead to pulmonary edema, lead to vasospasm, and lead to problem in ventilation perfusion mismatch, because there will be maybe few of these patients have a VQ mismatch as well. Now, what other diagnosis you will consider? Similar presentation, profound cardiorespiratory compromise. So few of them are there. If the patient will have an air embolism or pulmonary embolism, if the patient will have land up in anaphylaxis, if the pulmonary aspiration, if the patient will have an underlying septicemia leading to septic shock, if the patient will have a sudden STMI like ST segment elevation MI, or with underlying left ventricular failure because of the LVF, the patient may land up in myocardial infraction, or the patient may have a cardiogenic shock later on. So these all can lead to the presentation similar to that amniotic fluid embolism. Now coming to the few parameters like DIC score and minimum score I was talking. So as per your ISTH classification or ISTH DIC score, like your International Society of Thrombosis and Hemostasis is scoring, this DIC is the components for DIC is INR, first we all know, or it may have PT prolongation, fibrinogen, D dimer, or platelets. So either you can directly based on the level of INR. So if it is more than 1.7, the scoring will be only 2. So based on 2, you can't level this patient. Even you can level this patient as a over DIC, or sorry, on non-over DIC. Here DIC is negative because you have to put 5 points for making a positive for DIC. So PT prolongation less than 3, 3 to 6, more than 6, fibrinogen more than 100, less than 100, and D dimer normal or more than 10 times or more than equal to 10 times is severely increased. So that has to be taken care of. And then your platelet 0 is more than 1 lakh, then 50 to 100, and less than 50. So if the less than 5 point is there, it is negative. But the patient could have non-overt DIC, which can evolve into directly into a frank DIC. That's why ongoing concern for DIC has to be taken care of. And that's why this DIC score has to be repeated every 12 to 24 hours. So many of the times what we used to advise that you calculate DIC score once, but what we feel that the score is only 2, sir. So forget about that. Don't calculate the DIC score. It is 2 only, but no, maybe it will be in non-over DIC, and then it will convert to a true DIC with a score of more than 6 or 7. So always keep track on that DIC values, and every time the 12 to 24 hours the cutoff for seeing these values. Now coming to the Laboratory finding, just I have added like platelet count will decrease. This you all guys know that fibrinogen is less. The INR is prolonged. The PT prothrombin time is also going to get prolonged. The D dimer will be very high. You will get helmet cells as well and cystocytes. And now I think yes. This the similar, that's what a picture of over DIC looks like. If your score is less than means more than equal to 5, if it is less than equal to 5, you can label it as a over DIC, and then the value is early DIC, that is sepsis induced coagulopathy is there. This is early phase DIC, and then there is a overt phase DIC. In early phase DIC, you will calculate the SOFA score as well. So whether is a SOFA score is there or not. But coagulation and CNS factors are not included in total SOFA score. Here, they will include a total SOFA score. Okay. Okay. Now, the coming to the next part, that is your biomarkers. So what are the biomarkers? So these are the list of the biomarkers that you all can like it to start with activin, then your BNP, CA125, C1 esterase inhibitor, CEA, then your chromogranin A, then your endothelin, and then your interleukin 6, 8, and TNF alpha P55, collagen type 1, and terminal propeptide as well. So these are the few of the findings, right? So that you have to remember. And their relationship is already written there. Now, how are you going to manage these patients? So management of these AFEs, intubation and administration, and then 100% oxygen, positive pressure ventilation has to be given, and then large volume of blood, fresh frozen plasma and platelets and fibrinogen, and cryo as well for managing that DIC. Okay. Here at this point of time, you can also repeat ROTEM or TEG for seeing that graph or TEG graph, or for thinking of whether the cryo has to be added, whether the platelet factors has to be added, whether fresh frozen plasma is required, or whether tranexamic acid is required if rapid fibrosis is going on there. So you have to check that two parts in that TEG. You all know that TEG has two component like your coagulation and then your fibrinolysis, and then till your maximum amplitude, the coagulation we measure coagulation, and after maximum amplitude in ROTEM, you can think of fibrinolysis phase. Okay, now the similar case, now this patient was shifted, amniotic fluid embolism was managed, and then shifted to the obstetric ICU. And on third day of the ICU admission, the blood pressure, as I already discussed, that the blood pressure was stabilized. Other vital parameters have also started to improve. But now what has happened on third day, the patient was again, initially she was complaining of right upper quadrant pain. So we thought of HELP syndrome. Now this patient was complaining of epigastric pain with few episodes of vomiting. But now here the patient was presenting with hypoglycemia as well. And on fifth day of admission, the patient was pale, the patient was icterus, the patient was having a pedal edema, the patient was having a delayed sensorium disturbance in the sensorium or slight change in the sensorium as well. So till this point of time, so what will be the probable differential diagnosis that you will think of? Here again, the same dignities. I will be going to ask this 5 important questions, that what will be the what was the serious condition for which the patient was, we are dealing this patient for in postpartum period, and how will you enumerate the pathophysiology, and what are the important clinical features in these groups of patients, how will you make the diagnosis of acute fatty liver or pregnancy. Now from severe preeclampsia we'll land up to HELP, we'll land up to acute fatty amniotic fluid embolism, and then we'll land up to acute fatty liver or pregnancy. So how will you differentiate this HELP from AFLP? What are the steps of management that you will take care for managing this patient? And what will be the first sign? What will be the first sign of hepatic recovery? So this is again a very important question. So just look one by one. First, we all know, because we are talking about that serious condition. So here the mechanism is there. So what exactly happens? There are 3 places where these amniotic fluid, acute fatty liver of pregnancy will be creating a problem: at the level of placenta, at the level of circulation, and then at the level of liver. So what will happen in the placenta? So placenta will have a fatty acid oxidation defect at plus, which is also known as PFAO. So this PFAO, what it will do, because these pregnant patients have undergoing lipolysis, and they will produce high amount of free fatty acids, and these fatty acids will produce high amount of acyl CoA, and then enoyl CoA, and then 3-hydroxyacyl-CoA. So what all these will do? It will increase the oxidative stress. It will increase the myocardial dysfunction. It will increase the lipid accumulation, because these free fatty acids will be going to accumulate inside that mitochondria and posing more and more lipotoxicity. So what will happen here? LCHAT deficiency of enzyme is there. So this is your hydroxyacyl-CoA dehydrogenase. So this is one of the commonest enzyme which is found defective. This is postulated one of the mechanism for development of AFLP, and that's why the patient will have a lesser amount of acyl CoA as well as acyl CoA, because the conversion will be not there, and the conversion to ketoacyl CoA will be not there. No formation of this will be there, and more accumulation of hydroxyl acyl CoA, leading to more and more lipotoxicity. So what it will be doing? It will be increasing the free fatty acids level in your blood. Free fatty acids will be increasing the blood, more and more oxidative stress. So nitrosative stress as well as oxidative stress, and all those antioxidant fighting ability will simultaneously decrease. And that's why the liver will have a microvascular steatosis, mitochondrial dysfunction, and hepatocellular lipoapoptosis. So they used to ask which kinds of steatosis is there, macro or micro. Only microvascular steatosis is there if you'll do a histopathology of the liver. So here, in brief, the mechanism. So if you'll answer well about this free fatty acid oxidation and the deficiency of the enzyme LCHAD, then I think you may get a good marks. Now coming to the next point, we all are aware about this Swanson very commonly used criteria for defining or for diagnosing your AFLP. So these are the few important findings that you will look for. In the exam, they used to ask the hypoglycemia value, then bilirubin value, and then your ammonia value. They used to ask your ammonia value. It should be 65 microgram per DL. And then they used to ask about that renal impairment, how much serum creatinine will increase. So it will be 1.95 milligram per DL, and then serum. So these are the few important findings that they will ask. Few other patients may present with polyuria, but abdominal pain and vomiting is a very important common findings that you will see in this patient. Now, 6 or more criteria is required for the diagnosis. Okay. Now, how will you differentiate this help from? I got this slide from one of the paper, I think I was reading, and then I thought that it should be important for you all to remember, because there are 3 findings: TTP-HUS complex, then HELP, and then AFLP. So we all know that in HELP, the transaminitis will be there. AFLP, the transaminitis will be there. But AFLP, the transaminitis will be more serious in comparison with HELP and TTP. The hemolytic anemia will be less serious in AFLP, but here HELP will be more, and TTP-HUS will be further more. Thrombocytopenia will be less in AFLP. It will be more in TTP-HUS. And then your antithrombin deficiency, it will be more in your acute fatty liver pregnancy. And DIC is very, very common. DIC is almost always absent in TTP, and hypoglycemia is very, very common. And then these patients may present with mostly the renal insufficiency. So if you're going to diagnose this acute fatty liver pregnancy, so think of or see the component of acute kidney injury in that patient, see that frequent episode of hypoglycemia, see whether that DIC is there or not, because these findings differentiate your patients from HELP as well as TTP. Now, one more important finding that I have added, that these AFLP patients they have decreased antithrombin 3 level, which is a very, very common finding in AFLP. For additional, you can remember. Now, how are you going to manage? Yes, maternal stabilization. We have to focus on safe delivery. We have to avoid the longer pregnancy last the diagnosis, because if you're delaying the pregnancy, so the chances for landing up these patients in fulminant hepatic failure will be more. That's why expected management is not an option. Always delivery as soon as possible when the mother condition is stable, and there are no reports of AFLP resolving prior to delivery. So there are at least no reports that if you are not going to deliver, your AFLP is going to resolve. No, it is not like that. Okay. Now, management, pre and postpartum treatment should be supportive. Critical care environment, coagulopathy, renal failure, encephalopathy has to be taken care of. Plasmapheresis may be considered in cases where liver failure continues to worsen despite delivery. And in extremis, you can think of OLTX, like orthotropic liver transplantation, in these groups of patients. Okay. Now coming to the next, what are the initial signs of hepatic recovery? So hepatic recovery initial sign is normalization of the liver enzymes. First is improvement in the prothrombin time. So this is, I think, first most important aspect, that which is the first earliest sign of hepatic recovery. So if your patient is showing improvement in the prothrombin time, then I think it will be the best. Then normalization of the liver enzyme, ammonia, coagulation status, and then decrease in serum creatinine as well. Okay. Now coming to the next vignities, now from AFLP, I'm taking you to another scenario. Now her uterus discoloration has started to increase. Urine and recurrent non-bilious vomiting is there, which is now increased. On fifth day, the patient presented with AFLP, but now on seventh day, this yellowish discoloration is going to increase much. The patient this time was afebrile, drowsy, and has icterus. Now flapping tremor has arises. Already now flapping tremor has come up. Now blood pressure was still able to maintain. Pulse rate was a bit higher. SpO2 she was maintaining. Respiratory rate she was not tachypnic. Abdominal examination not much specific, no specific finding. No hepatosplenomegaly, no dilated veins over abdominal wall was there. But she has leukocytosis. She has thrombocytopenia. She has hyperbilirubinemia, transaminitis, and coagulopathy. But ABG was normal and urine depistic protein was also negative. Okay. Now, based on this, 5 questions. What is the diagnosis in this case? First, I would like to ask, and what are the etiological agents responsible for leading to condition other than your FLP? So what other findings that you will keep in your mind? And why this patient has persistent organ dysfunction, despite we have delivered this patient as an emergency cesarean delivery? And then the last question was, what is the role of TP in these groups of MASH patients for managing this patient? Now see another question, how these TP therapeutic, now these are the advanced question that you have to prepare. Okay, many of the student doesn't reach at this interval of time and they doesn't used to answer. Few of them used to answer and few of them doesn't have a that understanding that, okay, the TP has also a role, and then the limitation, the TP, the adverse effects of TP, and then the combination, whether you are combining this TP with your double plasma membrane absorption system like DPMAS. So whether this TP is combining with DPMS is improving the overall mortality and morbidity of these patients. Now we will able to learn this. I think this is the last part. So here, how will you approach? Patient is having a jaundice in the late pregnancy. So I will exclude, first I will like to exclude the pre-existing chronic liver disease and portal hypertension. These two important findings will be in my mind. And then I will root the common problem in these groups of subsets of patient like acute viral hepatitis or malaria. So if acute viral hepatitis or malaria will be ruled out, then I will further investigate the biochemical testing, whether the patient is having a thrombocytopenia or elevated LDH or with a background of preeclampsia. So I will think of help. First, if the patient will have a hypoglycemia with encephalopathy, ammonia is very high, and then patient is having going in DIC, I will think of making a diagnosis of AFLP in this patient. So both have different sets of management, but here important is both required a urgent antibiotic and urgent delivery antibiotic, and you have to take care of hypoglycemia, because if seizure will be there, the prognosis will be more worsen. So this is how you approach a patient who is presenting with late pregnancy, because you have to think of 4 differential diagnoses: CLD, portal hypertension, acute viral hepatitis, malaria, and then you will think of 2 diagnoses, HELP as well as AFLP. Okay, now come to the next point. So what is this PEX? So PEX is basically plasmapheresis. Apheresis means taking away. So it is designed for the removal of large molecular weight substances like autoimmune antibodies, like immune complexes, cryoglobulins, many of the time myeloma light chains, yes, endotoxins, cholesterol. Those cholesterol that contains a large amount of LDL, that like lipoproteins. So more than 15,000. Second, why they are designed? Because we want to remove if a substance, if they have a higher long half-life, and they are used for acutely toxic and conventional to resistant therapy. You have done all sets of management, but your patient is not improving. So then your PEX is important. But because I have already talked about your OLTX also, orthotropic lung transplantation, but here therapeutic plasma exchange is important to understand. So how these therapeutic plasma exchange is going to happen? So you just see that it is taking away, ferritic apheresis is taking away. So what we used to do, a blood pump is there. a blood pump is there. Now this pump will start working, and then you have to add some anticoagulant to it. Now it will be taking away the blood from a filter or from a plasma that based on the osmotic pressure, osmotic gradient, it will be there. And then simultaneously, you have to substitute with some of the fluids also, like your FFP or and all, and then it will from this plasma separator, the substance, the fluid will go to the plasma pump, and then the waste will be generated. Another problem is when you will give a substitution fluid, it will go to another pump, and then through this filtration of plasma, the plasma will be mixed along with this, and then again directly it will enter into the patient body. So this is how a plasma exchange has been taken care of. Basically, a plasma separator are there, and two plasma pumps are there, and one blood pump is there. So a substitution fluid is also needed. Okay, now come to the next part. So these are the few problems that will happen, allergic reactions in the form of anaphylactoid and TTP, and then paresthesis, hypotension, hemorrhage, clotting, hematoma, pneumothorax, infection. So these are few of the problems, adverse events. Now, coming to the proposed mechanism, one thing is that the TP help in hepatic recovery because it removes the toxic substances, and simultaneously you are supplementing with some coagulation factors and albumin as well, many of the times, because it has to be given. And then one of the Vitro study, they have shown that this TP, what it causes, it induces the superoxide dismutase, it inhibits the malonyl production, it protects against your oxidative damage, so it prevents against oxidative stress, it inhibits the upregulation of caspase 3 and caspase 9, and it attenuates the hepatocytes apoptosis. So these are overall the findings of using TPT, how the pathophysiology, how the TPP is working at a molecular or a genetic level, okay, at a enzymatic level. So this has to be remembered, how these upregulation and how these that oxidative stress damage, how this production of more and more superoxide dismutase. Okay, now combination, if you're going to combine this therapy with TP, especially in liver disease of patients, one of the major drawback is it will be not able to remove the substance which is less than 50,000 kilodaltons and non-selective natures that removes albumin. And if you talk about DP mass, DP mass is usually it uses a plasma filter to continuously remove the plasma, and it can remove even the medium-sized and macromolecular toxins without causing significant changes in the albumin. So this is the only problem with TP. If you'll see with DP mass doesn't causes problems in the albumin, whereas in TP, the albumin is also going to get removed, or albumin changes will be noticed in using TP. Okay. Now, one or two example based on this study, like Yao et al, they have reported that if you combine DP mass with TP, it improves the survival as compared to TP alone. So if you'll get a question that whether on combining both this, the result will be better or not, yes, on combining, the result will be better. Even if you combine TP with hemoperfusion or CRRT, like continuous hemodiafiltration, it shows improvement in the 90 days survival as compared to alone therapy of your TP. And recent meta-analysis also have shown that DP mass with TP revealed a greater improvement in bilirubin values and INR when it is combined with DPMS, and also the lower requirement of FFP is there. So three advantages with DP mass with TP when they are combined, like your improvement in the bilirubin and INR and lower requirement of FFP. But limitation is they have been predominantly perform in patients with hepatitis B related to acute liver failure or acute and chronic liver failure. That's why the larger cohort is still required. But as an exam point of view, you have to remember like DP mass and TP has a role. Okay. So this is all about from my side in short and crisp, because we have discussed around, I think, 29 scenarios, and we have started our journey from preeclampsia, then severe preeclampsia, and then we land up into your HELP syndrome, and then we'll further land up into acute fatty embolism, like amniotic fluid embolism, then acute fatty liver or pregnancy, then severe that hepatitis was there, and then how you are going to manage those patients, the patient in advanced stage of disease. So at this point of time, if you have any question, I'm happy to answer. I think obstetric domain is very, very important. I'm sure that many of you must be reading, and this is that clinical case scenario as well as that case-based discussions. These are always very important. These are only few of the topics that I have covered. Still, I have not able to cover like your pregnancy, sepsis in pregnancy, pregnancy with trauma, and then your viral hepatitis like hepatitis in pregnancy. Again, I have not talked about the physiological changes in pregnancy. Again, these are very important aspects, but definitely what I have told you right now, maybe you will be going to get one or two scenarios, like you will going to get these stems in your exam as well. Maybe I'm not very sure, because previous batches they have got few of the questions, because now they are asking the CTG, your fetal heart rate variability, all those things in that investigation part or images what they are asking. So I think you have to go, and you can all those go and read all those parts. Okay. Anyone you have any question? So I think all the best. If you don't have any question, and I'm sure that you will be all going to do well in your exam. Just take your time in the exam. Don't be in hurry, and just hear that question very carefully, and then you try to answer. Because as a teacher in the first academy, what happens when you used to take a live exam in the real scenario exam, what happens most of the time, that people know the answer, but they doesn't used to explain in series, so they miss few of the important points. And then after that, after a discussion in the debriefing session, they used to tell, sir, we used to forget these kind of things. Definitely you will read and you will forget 70 or 80% on the same day. But here, why we are here, only to make you practice more and more, so that in the real exam you all can do well and perform well and pass with flying colors. Okay. So all the best from my side. If you don't have any questions, or if you'll have any question, you can ask in from the first team. I will be happy to answer them. And please rate the class also, that what you doesn't like about this class, or what improvement that you want. I will be happy to get that feedback from you all. Okay. So if Sana, I think if no question is from their side, can we leave?
Thank you very much, Doctor. We are grateful.
Thank you. Thank you. So best wishes from my side, and hope you all will be pass this time for EDIC 2.